So, good evening, everyone, and this is Sri Vishwapal from Critical Care Forum. I'm so glad to moderate the session on this topic of IV to oral switch or oral to IV switch in ICU in a critical care unit. So, before moving on to topic, I just wanted to introduce our esteemed speaker, Akila Ulas Sonu. So, she has completed a PharmD from Srinivasa College of Pharmacy, Mangalore, Karnataka, and she was a senior clinical pharmacist in critical care unit at Believers Church Medical College Hospital for the past 3 years, and right now she is working as an intern pharmacist at Chemist Warehouse, Adelaide, Australia. So without any further delay, I would like to give the platform to Akila for a presentation on IV to oral switch or oral to IV switch in ICU. The platform is yours.
Thank you, Ishabal, for your kind introduction. So, good evening, everyone. Today, I'm going to present a topic on intravenous to oral and oral to IV switching in critical care unit. And my disclosure informations are the name of the presentation is IV to oral and oral to IV switching in critical care. My name is Agila Ullas Sonu, and the disclosure, I do not have any relevant financial relationships with any commercial interest. So today we are going to learn 5 objectives which is important in the switching of medications in the critical care unit. So first thing is understanding the rationale. The second one is the selection criteria. What are the selection criteria for the switching, and what are the specialized routes which is found in the critical care unit, and what are the barriers or challenges in switching, and the last one is the practical considerations in the switching. So why we need to discuss about this topic, why it is necessary. So we'll see. So whenever you are going to switch from oral to IV or IV to oral, you need to consider these 3 factors. These are the main 3 factors: why, to whom, when. Why you need to switch, to whom, whether the patient is the right patient, or the when you have to switch, what is the right condition, what is the right situation for the switching. So these are the main 3 factors you need to be ensure about while you are going to switching. So first objectives, that is the understanding the transition. So in this ideal route of administration, so this means it is an important clinical decision in treatment, a clinical decision in the treatment. The ideal route will help you to improves the absorption of the drugs, and this will manage the resource effectively, and this will improve the patient outcomes also. And the route selection criteria means you need to select the route appropriately for the correct patient in a correct way. You need to meet all the criteria for the switching, and whether you are going to switch from IV to oral, you need to meet certain criteria are there. Whether you are selected the route, it is appropriate for the patient conditions, and the intravenous versus oral administrations in ICU, how the IV and the oral medications are given in critical care patient, what are the criteria, how they are giving, whether any criteria or factors which influencing in the switching, and how long the patient is on IV or oral medication while they are on the critical care. And the last one is the antibiotic switching versus other drugs. See, in critical, in what it is not in critical care, wherever you are seen in hospital, there is more focus on the antibiotic switching. Not everyone is focusing on the other drugs which are going on the patient drug charts. First we are focusing on the antibiotics, but it is more important, it's equal important you have to given for the other drugs which are given to the patient. Whatever drugs the patient is taking, you need to go through all the each medications, not only the antibiotic, antifungal, whatever antimicrobials are going. You have to think about the other drugs, whether the other drugs like antipsychotics or antihypertensive, anti-epileptic drugs, you need to think about these drugs also needs the conversion or not. So These are the types of route which is commonly used in ICU. Like one is the enteral route. It is oral, sublingual, rectal, or nasogastric, nasovaginal, and peg tube. And the parenteral route is IV, muscular, subcutaneous, intraarterial, intrathecal, and intraventricular, epidural. So these IV, muscular, subcu, epidural. This is commonly used in ICU. And the in enteral route, oral, sublingual, rectal, RT, and vaginal peg tubes are many we can see in critical care unit. And other drugs like inhalations, this is most probably we'll use in critical, like transnasal and transdermal. It is not quite used in ICU, but in my practice I have seen these are the most relevant routes which is used in critical care. So we'll discuss about the therapeutic step up, like oral to IV conversion. In this topic, um, what we'll see in our practice, like everyone is thinking about the IV or the intravenous will give more absorption or more efficacy when you are compared to IV. This believes the IV administration is always more effective or better absorbed than oral formulation. But it is a misconception. It is often unfounded and clinically outdated in many contexts. Not see For example, levofloxacin, oral or IV, it is both are having above 90 percentage of absorption. So you need to think about whether you need to give IV or oral for that particular patient. If the patient is able to tolerate orally, you can switch to oral. There is no need to give IV, because the patient may get pain due to the IV insertion. The patient may feel some of the financial burdens. So these are some criteria are there. You need to check whether the IV or oral, whether I need to give to that patient. So it is not always you should go for the IV. There are particular condition you need to choose IV or oral formulations also. There is some of the drugs will give you the exact absorption, exact pharmacokinetics parameters of the IV formulations that you need to check before you are going to prescribe drugs for the patient. And transition from oral to intravenous medications in the intensive care unit is a critical decision that ensure the optimal patient care. The rationale for this conversion includes the following key factors. So these are the some of the reason why you need to give IV medication to that in a critical care patient. So one is the impaired gastrointestinal. Maybe the patient GI system will not tolerate the oral formulations. And one of other thing is a predictable and controlled drug dosing. See, IV formulation will give you predictable and controlled drug dosing, and it will reduce the drug other interactions and other complications also. And the critical intervention and the rapid response, you'll get a response within hours. You'll get the hours or minutes, you'll get the response from IV formulations. And special considerations, like some of the conditions, like if the patient is on NPO, like nothing per oral. For example, the patient may if the patient is undergoing any endoscopy or any gastrointestinal surgery, we'll put the patient for 24 hours for NPO, or for maybe for 48 hours for NPO. For that procedures, we'll keep the patient is for in NPO. If the patients comes after any complicated surgery, we'll keep them for NPO. And if the patient having any difficulties in swallowing, that's a condition called with dysphagia. If the patient is in unconscious, if the patient is intubated, if the patient having ongoing seizure, there is a risk of aspiration. And they have the patient having severe GI bleeding, hematemesis, melena, will give IV medication. If the patient is having again hypertension or shock, like cardiogenic shock, septic shock, you may give to IV for your better outcome. And a patient who disease state like that does not support to the oral therapy, like if the patient having meningitis, infective endocarditis, sepsis, pneumonia with AIDS, so you need to choose the IV formulation. And the previous or current oral therapies fail. If the oral therapy is failure, again you have to choose the IV formulation. And patient refuses to oral medication. Sometimes in critical care, the patient may be too much aggressive, or any psychological, or some of the ICU delirium, or any the patient having any psychological imbalances. So this patients may refuse to the oral medication. So we are not able to give them medications through oral. Then we have to switch to the IV medications. Any complicated surgeries like gastrectomy or something, bariatric surgery, any of the complicated surgery, then you have to pick up the IV formulations. If the patient having severe diarrhea, then you can choose the IV formulation. And the patient with a grade 3 or 4 mucositis, like inflammation of the mucous membrane of the gastrointestinal tract, it is especially seen in patients who are taking chemotherapy, or the patient may underwent any of the radioactive radiation. This stage you can see. Okay, so this slide will give you some of the impact of surgical, like gastric surgical procedure, which will give you which will affect your physiological stages. Like if the patients went any gastrectomy surgery or any bariatric surgery, this will lead to dumping syndrome. See, dumping syndrome means the food party, whatever food you will take, it will fastly moves to the small intestine. Okay, from stomach to small intestine. This is called the dumping syndrome. So this will affect the drug formulation that are dependent on the gastrointestinal transit time to trigger the drug release. See, some of the drug like entry-coated drugs like aspirin, pantoprazole, omeprazole, these are entry-coated drugs. So this should have the gastrointestinal impact. The pH should be there to dissolve these drugs. So these drugs will dissolve in acidic state. Okay, so what is the pH of our stomach? That is normal pH should be less than 7. If it is 3 to less than 7, that is acidic. If it is more than 7, it is alkaline. So this in this condition, the pH should be changed. So this will affect the drug release of the particular drug. And some of the gastrectomy surgery leads to increased gastric pH. Then it is the gastric pH, if it is increased, it is the alkaline stage. Then the entry-coated drugs won't dissolve in the alkaline state, and this will again lead to the reduced absorption of the drug, which requires the acidic environment for dissolution. And again, the pH irresponsive for that coatings. And post-surgery diarrhea, like truncal vagotomy, this will causes the post-surgery diarrhea. So like bariatric surgery can cause, example, high diet in fat, that can lead to diarrhea. So this will again reduce the available for the drugs to the absorption, and insufficient release of the drugs. And physiology factors in the gastrointestinal tract also affect, like the volume, pH, mucosal integrity. These all factors which will affect on the absorption of the drugs. So whenever you get any patient who underwent any complicated gastric surgical procedure, you need to ensure that you are giving the oral medications. If you are giving entry-coated medication, if you are giving any oral formulation, if you are giving, this will lead to the reduced absorption, and again the patient won't get the sufficient therapeutic outcome from that formulation. And so you need to ensure that. And this is the conversion of intravenous to oral step down therapy. The transition from intravenous to oral medications in the ICU is a crucial aspect of patient care, offering multiple benefits, including safety and enhance the patient comfort, cost effectiveness, reduce the risk of cannula site infections, earlier discharge. See why we need to switch from oral to IV. There is a advantages for this patient, so safety issue won't be there. Patient will be more comfortable for the oral formulation. There is no IV cannulation pain, there is no infection related risk factors, uh, cost effectiveness. Whenever you compare the IV formulation with the oral formulations, the oral formulation may lesser amount when you compare to the IV formulations, and you reduce the risk of cannula site infection, and the patient can get early discharge from the hospital or early discharge from the ICU to ward. So these are the main advantages when when you are switching from IV to oral medications. And the next thing is type of IV to oral conversion. See, there are three types of oral conversions are there. One is a sequential therapy. This means, I'll give you a simple example. You are converting injection pantoprazole 40 mg OD to tab pantoprazole. This is a sequential therapy. And the second one is the switch therapy. Like you are converting the IV medication to a oral equivalent with the same class, with the same level of potency, but it's a different compound, like injection ceftriaxone 1 gram BD to tab cefixime 200 mg BD. This is a different compound, but it's a different same class. Okay, and this the third one is the step down therapy. For example, injection, you are switching from injection heparin to warfarin. So these are the types of IV to oral conversion. We need to look at that. These are commonly in we can see in our day-to-day practice. More commonly, we are using these types of switching therapy in ICU, in ward also we are using. And IV to oral selection criteria. See, first one is received IV more than or equal to 48 hours. See, you have to ensure whether the patient is taken the IV formulation for more than 48 hours. In through this, you are observing, or the clinician is observing whether the patient is respond to the IV formulation, whether you get the patient got the therapeutic outcomes from the IV formulation, whether the symptoms improved or not, whether it is reduced or if it is worsened or not. Through this, within the 48 hours, what happened to these patients? What are the treatment failures or outcomes you get? So this is a 48 hours you need to check out for the switching, and tolerate oral intake. See, in ICU, what we are doing, like if the patient is on IV medication, gradually after 1 day or 2 day, we are gradually giving some sips of water through their mouth, or sips of any liquids like food, we are blending and giving through their RT tubes or orally. So we are looking whether they are tolerating to the oral intake, whether they are tolerating a sip of water. So through that, we need to assess the oral tolerance of that patient, and absorption and bioavailability of oral counterpart is almost comparable to that of parenteral form. Like whatever we earlier discussed, like whenever you're going to switch therapy, the counterpart of that medication, that IV medication, it is giving the appropriate absorption or bioavailability of that oral formulations. And for patient receiving antibiotics, the signs and symptoms are reduced or not, whether the microbiological reports are showing you that showing a positive evidence for the oral switching. So you need to wait. So So within this 48 hours, you will get the microbiological reports. Then you can understand, you can decide whether you need to give the oral or whether you need to give for the IV formulations. So these are the some of the selection criteria for the IV to oral switching. And and this table will give you medication which is suitable for early IV to oral switch. See, for example, acetaminophen 100 mg, like 100 ml, it is available as IV formula. And you will get acetaminophen 500 mg as a tablet. It's a ready made. You can crush it and you will get oral viability 85, more than 85 percentage. And furosemide IV, furosemide 40 mg tablet you are available. And this tablet also you can crushable. This tablet also have 80%, more than 80 percentage of viability. Like omeprazole and pantoprazole, these categories are Enric coated tablets. You cannot crush it, where their oral viability is 30 to 40 percentage less. Oral viabilities are there. If you crush it, then their viability will be again reduces. And ondansetron, again it is ready-made. You can't crush it. Again, it is a more than 50 percentage of oral bioavailabilities are there. See, in this case, these are some of the examples. There are every drugs there fine. Whenever you go into switching from IV to oral, you need to check the pharmacokinetic parameters of the drug. What are the other excipients, like, or any other additives are used in that particular formulation, whether their kinetics or metabolites change to any active or toxic metabolites, whether you can crush it or not, what will happen after crushing this enteric-coated sustained release or controlled drug release compounds, what will happen, how it will affect the absorption and therapeutic efficacy of that efficacy to that patient. You need to check all the factors, but this is not every time possible, because of the less formulations are available for the some of the drugs. And other drugs like anticonvulsant, um, H2RA inhibitors, and pantoprazole, levothyroxine. These are the some of the example. You can convert it and what dose you have to give. So if you are giving Levipil 500 mg TDS as a IV, then you can convert to tab 500 mg as a TDS or BD. It's depends upon the necessity of that patient needs. And valproic acid you can't give as a there is no tablets are available for that patient. And so these are the some of the example. You can go through that, and there are lots of article it will give you information about the transition from IV to oral and oral to IV. And now we are going to discuss about the specialized route of administration found in critical care. See, PEC, it is percutaneous endoscopic gastrostomy tube. There are two types of endoscopic gastrostomy tube is there. One is the G2 and one is the J2. J2 means it is jejunostomy tube. In this, the tube is fixed on the jejunal axis in the small bowel, and the G2, it will the axis will be in the stomach. And these are the some of the example. While you're giving through these tubes, like when you're giving aspirin, it is a dispersible tablet. What are the instruction you need to follow while you're giving through PEG tube? You need to disperse in water once. And see, while you are giving through a PEG tube, you need to break the feed before and after administration of the drug, but it is not necessary in all cases. So you need to check whether you need to break the feed while you are giving aspirin, atenolol, atorvastatin. So there are list of drugs are there. You need to break the feeding. So for aspirin, you're not required to break the feeding before and after administration. And aspirin also you can give through a J tube. And atenolol, it is available in oral and tablets, oral syrup also can be given as a undiluted form, and tablet you need to crush it and dilute in water. And again, the prolonged break of feeding is not necessary in atenolol. It's same as in atorvastatin and baclofen. And some of the drugs you can't given through the J2, like atorvastatin. If you are given through J2, it will again lose the efficacy. And the baclofen, use the tablets for the only baclofen tablets are used for the J2 administrations. So why we are saying this means the J2, it is in the small J2 insertion, that the access will be in the small intestine, and the G-tube access will be in the stomach. So some drugs needs the pH level to be meet to dissolve the drugs. So like aspirin, pantoprazole, they need a pH of acidic pH. They need to dissolve in the water, dissolve in the stomach. So errors when drugs are given via enteral feeding tubes. So this area will give you what are the errors are occurring when you are giving through the enteral feeding tubes like RT or J tube, PET tubes. And these mistakes are often the result of administering drugs that are incompatible with the administration via a tube, of not preparing the medication properly, and of using the faulty techniques. See, you need to ensure whether you are using the correct RT tubes, the size of the tube, and whether the insertion are done properly or not. Whether you need to, while after inserting this RT tube through your nose, you need to take X-ray whether the tube is goes whether the tubes in the lungs or whether the tubes in the gastropharyngeal tube. So you need to ensure for the proper administrations, and you need to ensure the size, and the area should be clean every day. You need to check whether there is no patches or any infections or any discharge um, from the site. And these inaccuracy can lead to the occluded feeding tube, reduced drug effect. Drug toxicity can also occur. See, if the tube is not in a proper way, the patient may lose the efficacy of the treatment. Sometimes the patient may get the complication due to this occluding of the feeding tube. Sometimes the patient may even death also may happen. And see, these are the some of the formulations which is seen in our daily life. One is the enteric coated medications like aspirin, bisagodil, pantoprazole, omeprazole. These are the enteric coated medications. This will increases the GI toxicity. See, if you are crushing this tablets, you may get the GI toxicity. This will affect the drug efficacy. So these formulations do not crush well and often break into small particles that may clog into the EFT end of this tube. So if you are crushing this tablets, you need to crush it well. Otherwise, if it is in a small particle, this will block the tubes, and this won't goes to the patient's stomach or any jejunal cavities. And some of the other products like extended release products like CD, controlled release, extended release, long sustained release, and extended tablets. These are the some of the formulations, like for example diltiazem, carbamazepine, metformins. These are available in controlled and sustained release formulations. So these can also destroy the drug's protective coating. See, what we are saying is once you are once you have started to crush, you may lose the 50% or 60% of the drug efficacy, and the absorption also will be lead to less, and the treatment failure may occur, and the dose dumping also happen in these certain cases. If you are looking to the sublingual and buccal medications like nitroglycerin, these are available in the sublingual. So these also alter the absorption, which could potentially reduce the efficacy. And special considerations with the liquid dosage forms. If you are not able to give tablets, we will switch to oral formulation like syrup, lozenges, or any suspensions, emulsions. So bulk forming laxative, mainly we are using some of the laxatives in to take the patients. So some of the laxative or suspension, this contains the xanthan gum, which can potentially expand in the tube, which will causing the blockage. And some liquid preparations are hyperosmolar. So if you are giving any large quantities of these products, it may disturb the GI also. So make sure that if any oral formulation which is contain any excipients or additives which may lead to any GI disturbance, or which may block your tubes, or which may reduce your absorption of the tab formulation, you need to check for that. Not only you have to go through all the components in the formulations, not only the main content, you have to go for the additives or excipients also. And the improper absorption. See, drug absorption depends on the drug's solubility and ability to permeate the intestinal mucosa. The distal end of the feeding tube can be in the stomach, duodenum, or jejunum. Drugs like warfarin, which is absorbed in high in the small bowel. Oral iron, this is which is dissolved in stomach and absorbed in the duodenum, might not be properly absorbed if they are administered via jejunostomy tube. See, this is why I earlier mentioned some of the drugs only dissolved in stomach, some of the drug only dissolved in small intestine or small intestine. So you need to ensure, while if the patient is in a PEG or a J2 or G2, if you are giving warfarin or iron or aspirin or recorded tablets, you need to ensure whether you will get the full absorption, or whether you will get any therapeutic failure or not, whether this drug will dissolve in this pH. So you need to ensure before going to administer. This is one of the example, like oroquinolamine. This is a ACE inhibitor. So this quinolamine having magnesium carbonate as a excipient. This is used as a binder, buffer, or a preservative. So crushing of this quinolamine will lead to the carbonate to increase the pH of the solution, which will cause the drug to rapidly degrade into poorly absorbed metabolites. So this is why I told you, like I mentioned you need to go through all the excipients, whatever mentioned in the formulation. You need to thorough about the excipients, what they are doing, or if you crush it, what will happen if the patient get any of the toxic metabolites, or the converted metabolites will affect the therapeutic failure of that patients. And now we'll discuss about what the literature reveals. So this is a study which is conducted by clinical pharmacist. So this study will this study will give you the quality improvement of intravenous to oral medications. So some of the clinical pharmacists in critical care, they conducted a pre and post analysis of the conversion of IV to oral conversion rates. So what they find, gradually after following target invention, they find out the missed opportunities for intravenous to oral conversion. So in the pre analysis, they find it what they can do, or where how much missed opportunities are there, and how much IV and oral conversions are there. What they did in the post, after their interventions, they they find it out the missed opportunities, and they reduce the missed opportunities from 37 to 21 percentage, and there is a 43 percentage of improvement. And IV to oral conversion rates are increased from 76 to 85 percentage, and the length of stay of the patient is reduced from 8.1 to 6.4 days after the post intervention. This study mainly indicate the importance of clinical pharmacists in the critical care, and how we can give the intervention to patient medications, especially in the conversions from IV to oral or oral to IV, and how they affect on the patient's therapy or the patient's other factors, like how they affect on the advantages for the patients, and clinical stages, and the physical stages, and the financial outcomes, and the hospital stay of the patient. So this area is the main thing what as a clinical pharmacist we can focus it on. So this study is mainly indicating the opportunities for the clinical pharmacist interventions, and how it is affect on the patient clinical status and the therapeutic sector. Next, we'll discuss about the barriers or challenges. From IV to oral, it is mainly the dissolution properties of the drug. Like earlier we discussed, if any patient having gastrointestinal effect or any post-surgical complication, it may affect on the dissolution properties of the patient, properties of the drug, and the patient adherence. Sometimes the patient want other to the oral formulation. They may some ICU delirium. It is common in ICU patients. And psychological impact on this patient, and inadequate maintenance and handling of the RT tubes. If the staff who is taking care of that patient, particular patient, if the staff or any of the healthcare workers who is taking care of that patient is not taking care of that RT tubes or PEG tubes or IV cannula, whatever cannula, RT tubes, whatever administration route is there, it may lead to the complication like infection, pain, tolerability of the patient. So you need to be check whether the tubes are appropriate or not, and you need to ensure the infection control is there. And dosing in equivalence issue, dosing inequalency issue will be there sometimes in IV to oral conversions, and lack of protocols or guidelines. There is no proper protocols or guidelines for IV or oral switching. You can have you will get guidelines or protocols for antibiotics or antifungals, but you won't get other drugs like antihypertensive, anticonvulsants, like other drugs. You won't get any protocols or guidelines. And inconsistent oral absorption, this is what we discussed earlier. And some of this the gastrointestinal dysfunctions. This is also a barriers or challenges if you will face in switching from IV to oral. And coming to oral to IV, you will feel catheter related infection. It is common in ICU patient because the patient may have the cannula for 5 days or more than 5 days or 6 days. You need to ensure there is no phlebitis or hematoma around the cannula, and there is no blockage, or you need to check out for the backward movement of that backflow of the cannula, and the financial constraints of the patient. Sometimes the patient won't able to give the able won't able to um, give the financial statements, and the unavailability of the IV formulations, poor venous access. So these are the some of the issues or barriers that we'll seen in while switching from oral to IV. And coming to practical considerations in switching, so there are some points while switching from IV to oral and oral to IV. This is an area what we can see from as a clinical pharmacist point of view. First thing, a clinical pharmacist should identify patient who receive these formulations and identify the need of medication in those patients. You need to ensure whether the patient need IV or oral, whether the patient need these much of dose, the frequency. And the second thing is regular follow-up is needed to check whether the patient's clinical status like WBC, vitals, culture report, clinical reports, whether the patient extubated or intubated, cannula related problems, size and position of the cannula, position of the trachea, size of the cannula, size of the tube, it is improving or not. So the condition of the patient you need to check every day, every minute, because it is more important in the switching of formulations. And you need to it is better to have a follow-up chart with you. So every day you can monitor the patient, every day you can note out what is the condition and what is the improvements is going on, what are the other things you can do, what are the intervention you can do. So it is better to have a flowchart of that for each patient. And if the patient is eligible for conversion, check whether the conversion was done. If the patient is if the patient signs and symptoms is improving, if the patient is extubated and intubated, if the patient is orally tolerating, so you need to ensure that the conversion was done. And it is mostly it is your responsibility as a clinical pharmacist responsibility to ensure the conversion was done or not. And inform the physician about the patient who are eligible for conversion but not converted within the appropriate time. You need to inform the physician about the patient condition, because you can tell she or he that is the patient condition is improving, whether we can change the IV to oral or oral to IV. So there is a continue conversation. There should be continue conversation between the clinical, between the physicians and other healthcare workers who are working with you in the critical care area, and makes two suitable recommendation protocols for the selection of an oral and IV medication for conversion. And earlier I mentioned to you there is no protocol or guidelines for every drug's conversion. So you need to prepare some recommendations or protocols as per your hospital rules. You need to have a protocols for the IV and the oral medication conversion switching, and they create a policy or a procedure for this conversion that you can make with your clinicians or your departments. So this will be helpful while you are switching. And review the feedback of the physician and monitor the patient's clinical progress after switching over, and convert the patient back to parenteral or oral medication if required. After switching also you need to observe the patient, whether the patient is tolerating the route, whether you are getting the appropriate clinical outcome from the patient after switching. You need to check, or you need to observe the patient daily basis, and constant communication with the patient relatives regarding their financial concern. See, some of the patient having financial burdens, they won't able to tolerate the some of the medications values. So you need to check, you need to have a constant conversation between the patients, bystanders or parties. So you need to talk about the talk about the cost of the medications, whatever going to the patient. So there should be a proper communication between the cost of the medications. And for extended release formulation, switch to immediate release. See, if you are in this cases, if you are prescribing any extended release, you can switch to immediate release formulation. This is one of the solution for switching. If you are breaking extended release, you can switch to immediate release formulations, and switch to IV formulation if oral formulation is not supporting. Okay, so this is the question. So a 78-year-old male patient hospitalized with 2 days history of fever, tiredness. His blood culture sensitivity report shows the presence of Corsari, which is sensitive to voriconazole, isvaconazole, caspofungin, and micafungin. So the patient is intubated and the RT tube insertion was done, and a hematoma on the both hands, and patient relatives raised the concern about financial constraint. So what is the answer is, this is the tab voriconazole. Why I'm saying you can't give any of the IV formulation, because the patient parties raised concern, and one thing is hematoma on the both hands are there. So IV voriconazole and tab voriconazole having the same bioavailability. They both have more than 95% of bioavailability. And if you comes to the rate of the medications, IV voriconazole have more than 5,000 range, and tab voriconazole you will get in some 2,000 or something. You will get 4 tablets. So in this so if you're facing any of such incidents, you need to think about the patient financial stage and patient physical stage also. So this is the one case. And the second case is a 60-year-old CKD patient admitted in the ICU has head and neck cancer with his pain medications include transdermal fentanyl 100 mcg per hour every 72 hours and IV morphine 40 mg every 8 hours as needed. Due to his current renal dysfunction, morphine was unable to continue. So what would be the appropriate medication choice for this patient? So we got injection acetaminophen, tab oxycodone, and the injection hydromorphone and tab aspirin. So the answer will be injection hydromorphone. Why is you can give a tablet because the patient have head and neck cancer, and you can give any of the injection acetaminophen and the tab aspirin because the injection acetaminophen requires the like renal adjustment. So injection hydromorphone won't require any renal adjustment. So in this area, you need to check all the parameters of that patient, whether the patient can tolerate oral or IV, what are the complications of, what are the disease complications of the patient, which drug require renal adjustment or hepatic adjustments. You need to check that also. And okay, so take home messages. Clinical pharmacist worksheet should be there. Early identification of suitable patients. Identify the barriers or challenges in switching and make a standardized protocol for switching, and provide knowledge to your consultant, junior doctors on NIDS related drugs and the administration. Give proper education to your healthcare workers, and daily communication between the critical care team members and your clinical pharmacist who are working with you. There should be a daily communication between you about the patient outcomes, and daily evaluation of patient catheters and other drug delivery routes to ensure the proper absorption and the proper accessibility and the proper infection control, and ensure the proper storage and availability and utilization of the drugs. Ensure the cost effective managements. So these are the reference. Thank you.
Thank you, Akila. So it was a great presentation, I suppose, because a lot of slides were so interesting, and it gave us many insights on switching between IV to oral or oral to IV. And actually,
Yeah.
very much grateful to be here with you. So
Thank you.
before ending the session, I have two questions with me. So one is
Okay.
based on your the first question what you have mentioned, right? So regarding the switching between regarding the selecting between IV and oral
Yeah.
oriconazole.
Yeah.
So the same way we have this linezolid, right? So linezolid we have both in IV and also in oral. But the almost the bioavailability of linezolid is also 99%. So in case of a patient is on a patient has an volume restriction or fluid restriction, so what will be the choice of formulation, whether it is an IV or it is an oral?
See, this is what I earlier mentioned. If you're the patient, you have said the patient is in volume restriction, then you can't give this 500 ml or something to that patient, because you have to give linazol as a TID or BDS for that patient. So one day, not only linazol, there are some of the other drugs also giving. If the patient is in a ICU, if the patient is, if for example, the patient is intubated, the patient is unable to tolerate through the RT tube, maybe the patient having any hematemesis or something, you can't give through RT tubes, then you can only way of giving its IV. Then it is a critical decision. So there is other thing will come, like fluid management, fluid stewardship, like antibiotic stewardship. This is an important area, where we need to give more care, like fluid stewardship, how you will adjust the fluid intake for that patient. After 4 hours or 2 hours, the feeding will start for the patient, okay, for 24 hours or 12 hours.
Mm.
So that also a big problem. Maybe if the patient having any CKD or something, if for example, if the patient having any on dialysis, it is fine,
Mhm.
okay, it is dialysable. If it is not, some of the drug is not dialysable, then you have to be you have to reduce the dose, or you have to reduce the fluid intake, you have to reduce the feeding, and feeding rate also you have to reduce. It's all depends on the condition. What are the criterias you have to meet, what are the factors, what are the disease complication the patient having, whether I can give this much fluid, or whether I can give IV formulation this patient or not. So it is a critical decision. So within 48 hours, whatever it is there, you need to give IV. If the patient condition is so bad, like if it is a patient is in a septic shock or any other of the cardiogenic shock, if the patient is in unconscious, in the multiple support, you have to choose IV. There is no other option. You can't give oral. So it is a critical decision. It depends on the clinician's point of view. You can't tell them, you have to give this oral because the lane is already having. You can't tell like that. It is a clinician point of view.
Okay, thank you. Actually, so it's yeah, I got a little bit. No, I have
Yeah.
actually got the point or idea about it. And one more slide which took me back to my early clinical rounds is your the slide which contained the formulation one. The
Yeah.
so
It's 10
yeah,
days.
initially when I went into critical care, I had so much of questions inside my mind regarding the formulation.
Yeah.
Uh, so the second question, maybe one I'm going to ask now could be something which is out of syllabus from today's topic. So,
Okay.
so the one is so don't get stressed out.
No,
Uh, so, yeah.
no
So,
worries.
so the question is, we are actually currently practicing few techniques like crushing of all the medications into the same mortar and pestle in the same time in a means together we are crushing it together, and you're diluting it with water, and then we are administering it. So how far the efficacy of the drug or will get reduced if you're going to administer together with crushing it in the same mortar and pestle at the same time?
Uh, yeah, it sometimes it's affect the absorption and efficacy of the drug. See, I have seen some of our staff is doing their mixing the tablets plus the syrup in the same water or pestle, and they're crushing and they're mixing with some of the water and they giving through the antidopes. So it's a inappropriate way of giving medications. So what I said, there are so many formulations are there: enteric, control release, sublingual, and some of the staff is giving sublingual as a crushed one. Okay, so they don't know how to give these specialized forms. So these are the specialized forms. Okay, so we can't tell you can't give without crushing this medication, because the in critical care we can't give like that without crushing, because the patient condition is like that only, and we don't have other formulation, other specialized forms for these. In India, we don't have, some of the forms are not available. So this is one of the barriers. So sometimes you need to be crush it. Okay, and ensure that you are crushing separately, because in that you will avoid some of the drug interactions or any some of the excipients additive reactions. So sometimes it may affect the it may transfer to the active metabolite to toxic metabolites also. Okay, so these are the some of the things you should ensure before crushing or before going to give. And you need to educate the staff who is taking care of that patient. You have to be more aware of the while giving through this enteral feeding. So enteral feeding also very very important in ICU, because if you have 10 patient, 6 patient or 8 patient may have RT tubes enteral feeding. So you need to be ensure you have to more vigilant about the what are the components on the medications. I mean, what are the components on the medicines out pages.
Yeah, so we have to consider all the excipient part and
Yeah,
the drug interaction which occurs if you are going to crush it together. So that's what.
yeah,
Yeah. And yeah, so actually your presentation was very good, and thank you so much for being with us for today, and hope we'll end the session.
yeah. Thank you.
Thank you.